R107. It's Professor Van Cott with your Comfort and Pain lecture. Just a fair warning, this is a long presentation. You may want to do it in two parts. There's a lot of nuts and bolts. I want you to understand why you are providing the care that you are for patients. So the first half of the lecture is basically nuts and bolts about pain. So pain, sometimes we call this the fifth vital sign. It's just as important as taking someone's temperature and blood pressure when you're doing your initial assessment. It's a hot topic these days. We have a massive opioid addiction crisis in our nation and probably all over the world. So we really are looking towards utilizing alternative forms of pain control. So with that, definition of pain, very simplistic. As I said before, it's referred to as the fifth vital sign. It is a very common cause of people seeking health care. 1 in 5 American adults, that's 50 million people, according to the CDC, seek treatment for pain being the primary reason that they're visiting the ER or a pain clinic or a doctor. So it is more prevalent in women, elderly, recently unemployed. That's an interesting thing for us right now with our coronavirus going on. We have a lot of people that are recently unemployed, so it'll be interesting to see if there's an uptick in those numbers of people seeking treatment for pain. And also persons that suffer from poverty or live in rural areas tend to seek pain control from healthcare professionals. So pain is a subjective sensation. Remember that. Pain is whatever that person is sensing. So they can tell you, my hand is burning, and there's nothing outwardly there that you can see. You've done MRIs and X-rays and all sorts of tests. There's nothing clinically that's visible, but they are experiencing that pain. So it is the subjective sensation. It is whatever they say it is. The other thing to know about pain, it's your body's response to avoid a threatened or actual tissue damage. So it's a mechanism, a natural mechanism to protect itself, to protect the body. So there are categories of pain, and apparently I start at number 2, not number 1. So you categorize pain according to where it is, when did it start, how bad is it, and what's causing it. Different types of pain. Think cutaneous surface, visceral. I always think about the vagus nerve, the wandering nerve that goes through your abdominal cavity. Sometimes people, when they have that visceral pain, they can't really tell you exactly where it is, and it's because that nerve, that big nerve, wanders all through and kind of winds around. So they might not be able to tell you exactly where that pain is. So the onset of pain is the other way we categorize it. Acute pain can actually turn into chronic pain. So you can have an injury, you fell off a ladder, you hurt your back. That initial pain is acute pain, but if that doesn't go away after 6 months, it's considered chronic pain. So just a little more, as I said, acute pain can last up to 6 months long. Initial pain, sharp pain, fast pain, those are just other words you might hear used for it. And the nuts and bolts, it usually travels through the type A delta fibers. We're not going to get too into that, but you'll see when we get through the management pieces why some of these pieces of information are important to you. Chronic pain is pain that sticks around for longer than 6 months, and it often impedes normal function. And it doesn't have to necessarily be a dull pain. It could be a more intense pain that folks are seeking means of treatment for. That kind of pain travels in the type C fibers. It is not easily localized. So you can't pinpoint exactly where that pain is. We'll get more into that as we go. So radiating pain, I think of, if you get a staple in your finger or you cut your hand really bad and that the whole hand is throbbing because of that. The pain is radiating from that tip of your finger all through the hand. Referred pain, I always think of a heart attack. So you don't feel that in your chest where your heart is. You might feel it in your arm or your back or your shoulder. Again, think about that vagus nerve in there, and it could be other areas of the body as well. So intractable pain, we're given this patient massive doses of morphine and positioning them at heat, cold, we've tried everything and we just can't control that pain. Intractable pain is very resistant to relief. Phantom pain is someone gets an amputation is the classic example of it. It's gone. It's not there. And they're saying, they got an above the knee left lower extremity amputation and they're telling you their left foot hurts. It's not there. Yet the nerves are sending those impulses. So this is why it's important for you to know the mechanics of how this is working. You remember the nerves send the impulses to the brain. So if that nerve ending is going crazy and sending that message to your brain, that patient is feeling that pain, even though it can't possibly be, their left foot's gone, it can't possibly hurt. They are perceiving that. It truly hurts. So hyperalgesia is excessive sensitivity to pain. I won't even notice a pinprick, yet somebody else goes through the ceiling over it again. However that person is sensing the pain, that's what they feel. A pain threshold is the amount of pain stimulation a person requires in order to feel the pain. Okay, I won't feel the pinprick, but if I step on a nail, I'm going to feel it. Pain tolerance is the maximum amount of duration of a pain that an individual is willing to endure. I don't know if I like that term, willing to endure, but some people have a different capacity. Some people might be able to go in and get a simple medical procedure with no analgesia, no sedation. Other people may require some relief. They're going to feel that pain sooner. Nociceptors are just pain receptors. We'll talk about those a little bit. Keep that in the back of your head for now. And pain perception is the point at which a person actually becomes aware of pain. So you might, something will happen and the doctor will doing a procedure. You don't feel that? Do you feel that? Most people feel it by that point, but this person has a different perception of the pain and a different tolerance. So, nociceptors. So let's just go through this. You can read that. I'm going to tell you the falx and tentorium are basically the dura mater in your brain. It's that thick membrane that surrounds, think durable. It surrounds the brain and the spinal cord. So the falx and tentorium are parts of that dura mater that encase the brain, large parts. So I think everything else you would understand in that definition. So nociceptors are non-adapting. They keep us constantly informed of the pain. Another way to say that is nociceptors are sensory receptors that send threat signals. They let the body know you're in danger. So pain stimuli, there's 3 different kinds: mechanical, thermal, and chemical. Chemical does not mean you spill some kind of nasty liquid from the lab on you. That would be thermal. That would be a burn. Chemical means what's going inside your own body. The nerves are sending chemical impulses throughout your body. So that's what we mean by chemical when we talk about pain stimuli. So a mechanical stimulus is pressure, squeezing, pinprick. Thermal, heat and cold. We get cold burns if it's cold enough. So chemical stimulus, remember I told you that it's those substances, we call it P substance, substance P, think P preparation. Substance P are those, you see those listed. This will become important when we talk about our nursing management. They are the first responders to stressors. They are released very rapidly, and they usually subside pretty quickly. They're very, very important for pain perception. So take a look at those substances, and you've seen them before. Histamine and serotonin. You've seen all of those pieces of substance P before. Keep that in your hat for when we talk about interventions. So 2 separate pathways that transmit brain impulses. There's delta A fibers. They're for acute pain, sharp pain, and type C fibers are chronic pain. So think C, chronic, and A, acute. The gate control theory. So this becomes important again with interventions. This is why we're going through all the nuts and bolts, I like to call it. So this was a theory developed by these 2 fellas that there's lots of videos on YouTube, and I'll probably show one when we get to class that kind of simplify what the gate control. You can look them up on YouTube yourself. This presentation was already so long, I didn't want to put more into it. So the gate control theory says that peripheral nerve fibers carrying pain to the spinal cord can have their input modified at the spinal cord level before transmission to the brain. So again, remember that as we go on. More about the gate control theory. Again, I'll play a little video at the beginning of class. If anyone finds a great one about gate control theory, because you see how much there is here about it, it's pretty important to how we provide care. Please feel free to share it with the class. So the stimulus can be shut down in several ways. This is what's important. Stimulation of the fibers by rubbing, stroking, massaging, vibration, application of liniments and other ointments. So you see where this is going. Release of endogenous being of internal origin, opioids. So yes, your body will produce naturally substances that help mitigate pain, um, including those substances there, endorphins, dynorphins. They have morphine-like action. For those of you that have had children, there's a massive amount of that secreted in childbirth. Electrical stimulation of the skin's sensory nerve fibers inhibits pain. So we'll get into TENS therapy. So electrical stimulation right on the skin will disrupt those pain impulses. So heat and cold, distractions, a lot of dentist office now. My children went to a pediatric dentist when they were younger, and they had videos, a TV screen mounted right above the treatment chair, and the kids would just sit there and play video games, and you rarely heard you know, crying, screaming, yelling at the pediatric dentist because they were so distracted. They didn't even know they got the Novocaine shot. They were busy playing their video games. So it is very, very effective. Also reducing anxiety. So we'll talk about some ways to manage pain that, that disrupt the impulses by relieving anxiety and stress. So I think we talked about referred pain already. The stimulation is not felt like the heart attack. We did talk about that. You might feel a heart attack in your arm. So this is just a neat diagram of different areas where you might feel pain and what they're related to. So look at the liver way up on your shoulder, kind of a funny thing, or at the base of your scapula, way off the mark. So that's just kind of an interesting thing that you can think about if someone comes in and, oh, my shoulder's killing me, and then you look at their liver labs and they're wacky. Well, there it is. So psychogenic pain, we talked about this before, someone coming in and say, my hand is burning up, but there's nothing there. So you can't find a pathological cause of that pain, but there's a psychological one there. So what do you think? Is that pain real? What do you do? We'll answer that in class. Neurologic pain. So neuralgia is sharp and spasm-like. Two common causes of neuralgia are the trigeminal nerve in the face and the sciatic nerve in the lower trunk. I think of shingles when I think of neuralgia. You know, shingles is basically chickenpox that lays latent in the nerve endings. And if you talk to someone that's had shingles and they've had the facial or the flank, it is extremely painful. That pain is in the nerve endings. So it's usually a causalgia is a form of neuralgia with severe burning pain. Phantom limb pain we already talked about. Intractable pain we already talked about. Arthritis and cancer, you just can't get away. No matter what you're doing, you can't get away. And it completely interferes with a person's quality of life. So this is a short video. I'm going by it. I'm trying to go by. So every time I get to a video in one of my presentations, it stops. That video just gave you an idea of how profound our opioid crisis is in this country. And it is a couple years old. I would be willing to bet that when we're done with the coronavirus, we might see an increase in our problems with the opioid crisis. So that would be a good place to pause and come back. We will spend most of class talking about the nursing management of pain. So I want you to go through this second section with a thought that we're going to take some class time to talk about nursing interventions. Non-pharmacologic, pharmacologic, and surgical are the ways that we can manage pain. So moving on, you'll see I relate this back to all of that stuff that we learned in the first 20 minutes of the video. So that gate control theory told us that we can interrupt those signals to the brain with stimulus on the surface of the skin. So electrical stimulators like TENS. TENS is a machine, a little tiny machine that you can put, they look like the electrodes from an EKG machine on a person, and it delivers tiny impulses, electrical impulses to the nerve, and to the nerve endings, and it just interrupts the impulses going to the brain. So there's also neurosurgical procedures for intractable pain. These are the surgical procedures are for really extreme cases. So one of them would be a nerve block, would be an injection of substances like a local anesthetic. We see this a lot for like surgeries, childbirth. We use nerve blocks for that. Acupuncture, very Eastern medicine. And so years ago, decades ago, in this country, we wouldn't have valued this very much, but now that gate control theory is providing a bit of an explanation of why this works. So that's a little description about acupuncture. Behavior modification. So we tend to, if someone has chronic pain like arthritis, in a healthcare setting, we will schedule medication to take away that the behavior of a person feeling like they're rewarded. They ask for, an opioid medication, and they have a high, a euphoria, so it's like a reward. So if you schedule the medications, they found that you start to dissociate the feelings of pain. Think that through. It's a little interesting. Biofeedback and autogenic training. So autogenic training is basically relaxation techniques. Remember that substance P, and remember I told you pay attention to the components in it. Think of where you've seen those before. You've seen that when you talk about stress hormones. So by decreasing the stress and promoting calm, you have less of those substances floating around in your body, and you're able to control. You actually can see a person's pulse and blood pressure. I don't know if there's some way to measure. I'm sure there is. Muscle tension. When they do relaxation techniques and relax, you can see all those physical things go right down. The blood pressure lowers, the pulse lowers. One of the ways we assess pain in a nonverbal patient is an elevated pulse, elevated blood pressure. Hypnosis. Another thing, you can just mitigate tension and stress and alter someone's perception of the pain through hypnosis. So you see all these alternative methods rather than going right for the opioids. We really need to think about it a little differently and try to get away from that, because it used to be for a long span of time, they were giving them out like candy, OxyContins all over the place. So we created a big problem with that. So cutaneous stimulation, again, this is like that TENS therapy is cutaneous stimulation. Also massage, just simple massage. So cutaneous stimulation, lightly rubbing the area, a heat or cold to the area, a back rub, a whirlpool. So there's other things, if you have a pretty decent injury and you're sitting there and someone bumps into the chair, something that would normally, you'd barely even notice it, and you just go through the roof. That pain just skyrockets. So if we think about that, these following interventions go along with that thought process. Avoid bumping the bed is at the bottom, but using a turning sheet for someone so that body stays in alignment, supporting the joints and the limbs. They always tell you put it on a pillow, put your hand on a pillow if you have an injury to the bone break or whatever. So that will just reduce extra motion there. Distraction, sorry, I went too fast. We went past distraction. There are studies out about, I'm talking about the last slide, sorry. Studies about music therapy. One of our nurse researchers did a huge program of research on that, and it is astounding. They found it to be as effective as giving morphine in some cases, and it giving patients music of their choice through headphones in the hospital post abdominal surgeries. They asked for way less pain medication, markedly less. They were off the surgical unit much faster. They recovered faster. Their whole demeanors were just better throughout the process. So it's really pretty powerful, and it doesn't necessarily have to be music. It can be conversation with a family member, friends, other patients, watching TV, movies, any kind of distraction. So guided imagery is another relaxation approach. Ice and heat. I personally can't stand ice on an injury. Most people, it'll reduce the inflammation, and I'll put heat on anything. It does wonders for me. But remember, when you use ice or heat therapy, that you really need to monitor the skin at that area. You could cause a lot of damage. I've seen patients, I love heat. You give them a hot pack and not wrap it in a pillowcase or whatever. You put something in the microwave and it actually burns their skin. So we don't want to create another problem while we're curing the pain problem. So just be careful. So these are just guidelines for the assessment of the patient with pain. You're going to assess their response to the pain experience. Determine if the pain is acute or chronic. We treat them a little differently. Assess the factors that influence responses. So remember that culture piece that we talked about? Different cultures, some cultures are very stoic, some are very expressive. You need to realize that, because pain whether it's expressed or not by the patient, pain will impede healing. So those cultural factors are important for you to have a little bit of awareness of. Previous pain experiences, they've been through this before, and maybe that's a good thing, maybe it's a bad thing. I know with my second child, my first child, when I went in with labor, I was just so anxious and nervous because I had seen so many movies and videos and heard so many horror stories, and it really wasn't that big of a deal for me. So when I went in for my second child, I had my own experience to go back on. And that will work the other way too. If you've had a really awful experience, it heightens your stress level and you're going to respond differently. Meaning of the pain experience to the patient. Remember, it's very subjective. And all patients will have unique responses to pain relief. Like I said, don't ever offer me ice. I hate it. I like heat. And it could be something, you know, a sprained ankle. Heat will feel wonderful for me. So, but the rest of the world puts ice on it. So it's very unique to an individual person. I talk about Tylenol. If you give me one regular strength Tylenol, good night, I'm going to sleep. It puts me to sleep. It has that effect, so I rarely ever take it. That doesn't really happen to anybody else I know. So everybody's response to the strategies is going to differ. So I think we talked about this when we talked about therapeutic communication, the phases for assessing pain. There's just a few slides here with different assessment tools, just to give you an idea of what's out there. So this would be someone that's not able to verbalize. Different things that we could use. These are all psychometrically tested scales, so they're valid in a healthcare setting. This is actually the scale we used in dementia. When I work per diem, I work on a dementia unit. So this is the scale that I most often use. So even if that person is verbal, they're talking gibberish, so I don't understand it, and I'm going to use this scale. So we'll put that in practice in clinical and lab down the line. So nursing diagnosis. So pain diagnosis, okay, pretty simplistic. Pain or chronic pain is the nursing diagnosis, but that could lead to many other things. So we're going to think about that in class, about other diagnoses that come about. And maybe it's they're not moving around, maybe they're depressed, maybe you know, they're not moving around and now their skin breakdown because they can't move because of the pain. So a lot of offshoots related to pain, and those are things that you need to be on the lookout for and plan for. So planning. So the overall goal is to prevent, modify, or eliminate the pain. We can't always completely relieve the pain. So, you know, the patient needs to have a reasonable expectation of, maybe they're going in for a procedure, so you're going to do some teaching prior to. You know, you will have some level of pain. Most patients say, blah, blah, blah. You can share that stuff. It's your body's response to reduce the chance of further injury. So really, if we could, and we completely took away pain, and people maybe had an abdominal surgery, and oh, we gave you great medication, you feel no pain at all, and you go and you're lifting grocery bags, carrying them up flights of stairs, and you do more damage. So some level of pain is actually good. It prevents you from injury. It just needs to be at a level where the patient can function. So implementing plans for pain management. There's two basic things, pharmacological and non-pharmacological. So we often go right for the medication. That's our culture. That's our society. We tend to want a pill for everything, a quick fix. But the major thing is to acknowledge that you believe them. You believe there's pain, even if it's you know, a phantom pain and the left foot is hurting. You're not going to say you don't have any left foot, it can't possibly hurt. It does. If they're telling you it hurts, it hurts. So there's a lot of misconceptions about pain. We talked about in the beginning, women tend to suffer more pain. Well, do they really? Or is it because men are supposed to be tough and macho and stronger and they don't express that they have pain as readily as a woman might be, because it's not acceptable in our culture. So assisting support persons. So, you know, you have an elderly person that has severe arthritis. It's hard for that caregiver, that support person that's taking care of them, and you need to, as much as you're teaching your patient, you're also teaching their support person what they can do to help relieve that pain. And then fear and anxiety associated with pain. We talked about that substance P and those different hormones that are circulating in your body that cause those psychological responses, the anxiety type stress responses. So to mitigate that a little bit helps a person be receptive to the pain relief. So implementing. We have the pharmacological, you're going to give pain meds. You always assess the if that pain med worked or not. And most facilities, it'll automatically come up about a half an hour to an hour after you give any pain medication. You're doing that whole assessment again. Did it work or did it not? We need to know that because we need to take a different course of action if it didn't. So these are just a list of different ways that we can deliver pain medications. There's liquid morphine, sublingual, we give to our hospice patients. We have patches. We have patient-controlled pumps that the patient can actually push a button to give themselves a boost of something if they're in severe pain. We now have IV Tylenol that I hear is extraordinarily effective, as good if not better than morphine, and it's not opioid, but it's at this point very, very expensive because it's pretty new. So all sorts of different pharmacological things that we can use for pain. The non-pharmacological, we talked about a bunch of those, and we're going to spend some time in class. We'll split up in groups, and each of you will take different ones to research. But these are fantastic, and I love that they have a warm shower. I can't tell you, I worked on an orthopedic floor, like a step down, a rehab unit for a while, and how happy people were to get out of the hospital and have their first shower, and they would actually report that they felt so much better, their pain was so much lessened just from having a warm shower, clean sheets. It goes a long way, and you wouldn't think it's a little removed from actual pain management, but it has a huge impact on someone feeling good. Anticipatory guidance, so you're teaching patients I like to teach before they go into surgery, because when they come out and they're in a lot of pain, they don't necessarily digest all this information. So I like to do that before you go in, and then you're going to it's going to be just a reminder when they come out. You know, you had an abdominal surgery, hold your stomach with a pillow. All sorts of things you can do for that. Cognitive behavioral interventions, we talked about the distraction and relaxation, therapeutic touch, and hypnosis. So, and then, you know, I talked about how it'll automatically pop up a half an hour to an hour after you give a pain med to evaluate the pain response. Well, even if you didn't give a medication, like when I do this at the hospital, they'll ask you if you used other things. Did you change their position? Did you was there some kind of distraction? It's a good way for the next nurse to come in and, oh, well, you know what? This patient loves to watch old movies, and they didn't have pain medication all shift because they watch back-to-back old movies. Well, that's kind of nice to know. So we want to evaluate that, share it through verbal or written feedback. Ongoing verbal written feedback from the client and the family is integral to this process. So you are actually going to go back and ask them how they're doing. So the rest of this presentation after the video is just some questions for you to review. This video is a great, very short 2-minute video about the teach-back method. That's really important for you to know. We use it all the time in nursing. Pain medications is a great way to show you the method. We have exam 2 coming up, so we're hoping with this longer presentation we can have a little bit shorter class. We'll have some interactive activities to do. Of course, the beginning class, as always, will be an opportunity for you to ask questions as you go through this presentation. Don't get too bogged down in that first half of the presentation. I just wanted you to have an awareness of why certain methods of pain management will work. So that's it. Have a great rest of your day. So that was a very short 2-minute video of the teach-back method that we use as a means to make sure your patient understands their medication or any kind of treatment that you want them to do when they go home. We're going to put that in process in class. You guys are going to teach each other about different pain management techniques. And I think the last few slides of this are all questions for you to review. We can talk about them in class. I think these ones are